Hi, I'm Shelley Fold-Nasso, CEO of the National Coalition for Cancer Survivorship. I'm thrilled today to be interviewing Dr. Emily Tonorezos, the new director of the Office of Cancer Survivorship at the National Cancer Institute. Emily, thank you so much for joining us today.
Thank you so much for having me, Shelley.
So I wanted to start with you just telling us a little bit about your background and how you became a survivorship clinician and researcher.
I am a general internist, and I trained in internal medicine at Columbia Presbyterian, and I loved internal medicine and the problems of complicated and difficult to treat patients. But I also felt a calling and a desire to do something a little bit more than just treat patients in the clinic. And so I went to Johns Hopkins and did a general internal medicine fellowship, which is like a public health fellowship. And in that fellowship, you learn a lot about how you can frame research questions so that you can have an impact on more than just the patient that you're seeing in the clinic, and how you can think about problems and think about solutions for large populations of people. So following my fellowship, actually, the survivorship program at Memorial Sloan Kettering was growing. And Kevin Effinger, Mary McCabe, and Chuck Sklar were looking for junior faculty to come on board and to grow the program. And so they recruited me. I was thrilled beyond belief. And also, actually, what they gave me was what's called protected time in academia. And that means that the institution, or in my case, the survivorship program, pays for your time so that you can read and work on grants and write papers. And it was an incredible opportunity. And it really gave me that support and time that I needed to start my research.
And what are some of the things you researched?
Well, coming from internal medicine, my number one question was around obesity. And obesity is the largest, prior to COVID, was the largest public health crisis facing this country. And there really is no problem like obesity when it comes to how complicated it is, how difficult to treat it is, how it's so wrapped up in behavior and self-efficacy and health, all of the different aspects of internal medicine that were interesting to me, including social determinants of health and financial and economic aspects. So it's a fascinating problem. And what we know is that many cancer treatments put you at risk for obesity. And so I was just fascinated, and I jumped right into the opportunity to think about how are cancer survivors eating, what could we be doing to help them develop healthier eating habits, and what can we do after the fact if you have a cancer survivor who's struggling with overweight or obesity, what could you do at that point to try to improve their health and their risk for subsequent cancers?
And that's so important, because we did a survey this summer of cancer survivors, or we released it this summer, and some of the two of the top areas of concern for cancer survivors post-treatment, and where they felt like they weren't necessarily getting the information they needed, was on physical exercise and nutrition. So that's really important. So how did you decide to take on this new role of the director of the Office of Cancer Survivorship, and what excited you about the opportunity?
About a year ago, Deb Mayer hosted the Research Priorities in Cancer Survivorship meeting at NCI. And actually, that's how we met, Shelley. And at that meeting, Paul Jacobson, who's in the Division of Cancer Control and Population Science, approached me and asked me how I would feel about public service. And I don't know what it was exactly, but something about the way that he asked that question really tapped into my desire to serve cancer survivors in a meaningful way and to develop the field and the research and benefit the patients in a way that I hadn't up until that point. And honestly, everything that I've experienced since agreeing to the job and starting this work has just confirmed all of my greatest dreams about what it would be like. First of all, it's a massive platform for improving the work. First of all, it's a massive platform for the work of improving the lives of cancer survivors, their families, their caregivers, people living with cancer. I love that it's right in this intersection between oncology and primary care. That intersection, I think, is in a crisis point right now in the United States. And I feel like I have a very unique perspective as a primary care provider who has worked in an oncology setting and taken care of cancer survivors at a cancer center. I love teaching and mentoring, and being in this role gives me a tremendous opportunity to support researchers, not just through funding opportunities, but also through, guiding ideas and survivorship resources that we can offer them. And I also think this is an amazing time to be in this office and to be in the field, because in the last, I'm going to say 5 to 10 years, we have, first of all, an amazing renaissance in oncology where patients are being treated more successfully than ever before. And the advances that are being made are really leaps and bounds over what was happening even in the early 2000s. So you have a tremendous expanse of the survivorship population and the population of people living with cancer, at the same time that we have the moonshot and the STAR Act and attention from Congress around issues of both cancer treatment and what happens to patients who either are finished with treatment or are continuing to live while getting cancer treatment or living with advanced and metastatic disease. There was a paper recently by Nadia Howlader about advances in non-small cell lung cancer, where she demonstrated that for the first time in many decades, the population of people who have finished treatment for non-small cell lung cancer is growing and survival is improving in a disease that really very few advances have been made for a long time prior to that. So I'm thrilled. I feel like this is a great opportunity and a great time to be in this office for me.
So you get to help people on kind of the individual level as well as the big picture policy level. And so that's kind of a nice mix in your job.
That is something that you learn about in public health school, that if you can think like a public health researcher, you can benefit more than just the patient that you're seeing in the clinic. And I loved that aspect of public health school and learning how to be a public health researcher. And I really feel like this job is just putting that type of opportunity on a huge stage.
So since you've started, obviously starting a new position and doing it in the middle of a pandemic comes with a big learning curve, and you've spent your first few months getting to meeting people in the community, listening to survivors, learning how NCI works. What are some of the insights you've gained in your first few months on the job?
Actually, I think that working at the NIH is a lot like working at Bellevue Hospital. So my first job right after fellowship was at Bellevue, which is a city hospital in the city of New York. And it's a hospital that struggles from a lack of resources, but a place where the people who work there are so dedicated to their jobs and to caring for the people of the city of New York that you feel every day when you get into work, you feel this tremendous energy and sense of purpose. And everyone who's working there, even the people who are overwhelmed and they, are struggling with the workload, or maybe their Zoom call is dropping or various things are happening, you feel really, truly like the work you're doing matters, that you're helping people, and that it's showing up and giving your best is vitally important to the people you're trying to serve.
Great. I'm so glad that you've had such a great introduction to it, even though you're joining at a time when you can't be there in person and have to do everything remotely. I guess we're just all still adapting to that new normal for now. So we at NCCS have been talking a lot about the needs of people with metastatic and chronic cancers with respect to survivorship. And I know this is a concern that you share. And last month, we convened a group of people living with cancer to talk about what it's like to live with metastatic cancer and what are some of the gaps that they see in both the care that they receive and in research. So I want to thank you and your colleagues from NCI who joined us to hear from these advocates. So what were some of the takeaways or aha moments that you had during the conversation with those advocates?
Well, the first thing I want to say is that when NCCS commissioned the Office of Cancer Survivorship and when the definition of cancer survivor was codified, it was always intended to be every person from the time of diagnosis. But what we saw was that most research, so-called survivorship research, most survivorship programs were geared towards people who had finished treatment, and some are even called post-treatment programs. And what we realized over the last few years is that we have to, first of all, be specific in the definition to make sure it's clear that we do mean every patient with a history of a diagnosis of cancer, as well as caregivers and their families, but also that you don't have to be done with treatment in order to have survivorship needs or in order to qualify for the field of survivorship research. And so building off the definition as it has evolved in that way, I think that's an important place for me to be, because that work is ongoing, and I'm really picking up the torch where Julia Rowland and Deb Mayer had left it for me. I will say, when speaking to the advocates, first of all, I was concerned, and I continue to be concerned about the language that we use to describe people living with cancer. And I was glad to hear them say, for the most part, living with cancer seems to be a phrase that is generally agreed upon. But I think the language in survivorship research and how we refer to this population, we're going to be grappling with that for a little while longer. It's not totally solved, I would say. But I was glad to hear their perspective on it, and also to at least have some words that I could use in talking about people who are either on chronic treatment or living with cancer in some other way. And so I really appreciated that. The second thing I learned was that some are excluded from survivorship resources, either in their clinical program or even through survivorship research. And there are so many studies where the focus is on early stage patients, somewhat unnecessarily, quite honestly. And one of the things I took away from that session is that we need to take a cold, hard look at the work we're doing and whether patients who have advanced or metastatic disease need to be excluded from survivorship research in the way that they have been historically. If there's not a scientific purpose, does that really need to occur? And finally, I will say that there was a lot of talk about this burden of explaining your diagnosis and your treatment to doctors and other providers. And especially from the young woman who is living with neuroendocrine, which is a very rare type of tumor, that she was almost in every encounter explaining her diagnosis, explaining the prognosis and what kinds of treatments she's eligible for to people who she's seeing in a medical setting. That is really intolerable, actually. So that I took that away and said that we cannot, like, that has to be solved. We just cannot let that go on. So obviously it touched me, my heart really goes out to her and to the many, many people like her who feel that constant burden of having to explain themselves to people who are taking care of them in a medical setting. So anyway, I will try to get off the topic, but I found it incredibly moving. I thought the experience of meeting with the advocates has been one of the highlights of my time in this role so far.
Well, I think, I think the experience is not unique in terms of, the patient has that burden of being the glue that holds everyone together in their care team, and has to be, educating them about what is happened to them, what the treatments they've had, what issues they have. And I think we really just don't have the kind of care coordination and integration of care that we need to have. So I think your discussion about the role of primary care and how we in oncology can work better with primary care is so important. What do you think? Do you have ideas for what we need to do to better integrate primary care into oncology care to make that not just the transition for post-treatment care, but just to make the situation better for cancer patients throughout their cancer treatment and then beyond, to have that primary care physician in as part of the team and not just an afterthought while someone's going through cancer treatment and they consider their oncologist their primary care provider.
Absolutely. I agree with every word you said. So first and foremost, it can't be that the primary care provider gets involved after treatment is over. That's just too late. And I love the study that Kevin Effinger is doing on blood pressure in women with breast cancer, where he's engaging primary care providers in the effort to make sure that women who are being treated for breast cancer can stay on their blood pressure lowering medicines, and really explaining to both the oncologist and the primary care provider that holding those medications is not a good idea, and that treatment adherence to medications, including blood pressure medications, is completely feasible during treatment for cancer. So his study, which was funded under this care coordination RFA that came out last year from NCI, that study and studies like that, I think, will help move the field forward in terms of integrating primary care into oncology practice. The other thing I would say is I do think that there is probably more that we can do by way of the electronic medical record. And there are some existing projects and also some opportunities for funding around improving communication between providers using that medical record. And so I think there's some solutions hopefully on the horizon, but there's no question that it needs attention and we need to figure this out.
So last question I have for you. How do you envision working with advocates in your role at the Office of Cancer Survivorship?
So the Office of Cancer Survivorship, as I really do not need to explain to you, has a unique and wonderful history of being born out of advocacy, and specifically NCCS, but the advocacy community in general has been incredibly supportive of this office, and I expect that to continue. I think advocates are very important for informing how we understand the problems that survivors are facing. They give us perspectives and define our research questions. And already, personally, I have benefited from input from your group. And so I know that this relationship and these types of relationships are only going to be more important going forward.
Well, that's wonderful. I'm happy to hear that. And we will stay ready to help in any way we can if there's ever questions that you have or where you need advice and input from survivors. We have an incredible group of advocates that we work with, who you met a few of them via Zoom, but we can bring them together to help, to give their perspectives on issues as you're thinking about how to frame questions or, where you want to put attention and emphasis. So we're grateful that you're open to working with advocates and that you listen to them, because I think, they want to be heard and they have a lot to say about what they've been through. And, if you're going to ask, you have to listen. And sometimes you hear something different than maybe what you thought you were going to hear, but it's important to listen and take that advice and use it as you go forward. It's not the only perspective, but it's the most important one, really, when it comes to what we're doing is trying to help improve the lives of cancer survivors.
I wanted to point out there is an NCI Office of Advocacy. If anybody wants to get in touch directly, you just go to cancer.gov/advocacy. And I agree with you completely. I agree with you completely. I have to say that the relationship with advocates and these types of conversations, I never had an opportunity like this when I was, working at a cancer center and just taking care of patients and plugging away at my little research project. So the opportunity to engage with you guys has really just been tremendous for me. I'm so appreciative.
Well, thank you so much for your time today. I really appreciate it. And we are so excited to have you in this new role and look forward to continuing to work with you over the years.
Thank you. Me too.